Welcome to the Immunology Serology lecture on syphilis and Lyme disease. Syphilis and Lyme disease are both caused by bacterial pathogens. They are somewhat unique in that they are spiral or helically shaped and are therefore classified as spirochetes. The spirochetes are divided into three genera: Treponema, Borrelia, and Leptospira. Treponema pallidum is the causative agent of syphilis, while Borrelia burgdorferi is the causative agent of Lyme disease. There are several species of Leptospira that can cause the disease leptospirosis, including Leptospira interrogans, Leptospira wheelii, and Leptospira alexanderi. Spirochetes are long, slender, helically coiled bacteria that are hard to see with a typical bright field microscope. Thus, they require dark field microscopy. They have periplasmic flagella. Periplasmic flagella are located between the cell membrane and the outer membrane. Therefore, when they rotate along the length of the bacterium, they cause the spirochete to rotate like a corkscrew, which causes forward movement. The spirochetes have relatively few surface antigens, which makes it more difficult to develop laboratory tests for identification. Because of this, and the fact that spirochetes are difficult to culture, laboratory methods for detection and identification are primarily limited to serology. Leptospirosis is a relatively uncommon zoonotic disease caused by the bacteria Leptospira. In humans, it can cause a wide range of symptoms that include high fever, severe headache, chills, muscle aches, and vomiting. Patients may also be asymptomatic. The majority of cases are mild and rarely fatal. However, around 10% of people, usually the immunocompromised, will develop a severe form of the infection called Weil's disease. The aforementioned symptoms are often present, but may also include jaundice, abdominal pain, diarrhea, and a rash. Left untreated, leptospirosis can result in kidney damage, meningitis, liver failure, and respiratory distress. The mortality rate in severe cases is around 10%. The incubation period is generally around a week, but can be as short as 2 days or as long as 4 weeks. Outbreaks of leptospirosis are usually caused by exposure to water contaminated with the urine of infected animals, such as cattle, pigs, horses, dogs, rodents, and wild animals, hence the term zoonosis. Humans become infected through contact with water, food, or soil containing the urine of these infected animals. This may happen by swallowing contaminated food or water, inhalation of aerosolized contaminated water, or through contact with broken skin. The disease is not known to be spread from person to person. Leptospirosis was made a notifiable disease in 2013 and is confirmed by laboratory testing of a blood or urine sample. Treponemes other than Treponema pallidum exist that are pathogenic to humans. Some are even non-pathogenic, such as T. dentincola, which is considered normal oral flora. The pathogenic treponemes are identical serologically and morphologically. They are only distinguished by the disease they cause and the endemic region where they are found. With the exception of Treponema pallidum, they are typically contracted by skin and mucosal contact with infected individuals. They are not transmitted or contracted by sexual contact and therefore do not cause venereal disease. For example, Treponema caratium causes a skin disease called pinta. It causes patches of depigmentation in the skin and occurs in Mexico and Central and South America. Treponema pertennue causes the disease yaws. It is transmitted through contact with the fluid from infected skin lesions, and therefore it too is not a venereal disease. The infection primarily targets the skin, bones, and joints. Symptoms include fever, joint pain, and ulcerative lesions. The disease mainly occurs in the Caribbean, tropics, and South America. Poverty, low socioeconomic conditions, and poor personal hygiene facilitate the spread of yaws. About 75 to 80% of people affected are children under 15, and they constitute the main reservoir of the infection. The incubation period is generally around 3 weeks, but may vary between 9 and 90 days. Without treatment, infection can lead to chronic disfigurement and disability. Diagnosis is often made based on clinical presentation. Serologic tests are available, but cannot differentiate between current and past infections. Currently, the preferred testing method is PCR. Yaws is a treatable disease. It is easily cured with azithromycin. However, there is currently no vaccine available. As a disease, syphilis was first described as early as 1495. In 1905, the causative agent was discovered and identified as Treponema pallidum. In 1906, the first diagnostic test was developed, called the Wassermann test. This test is based on exposing patient blood or CSF to reagent antigen, which is bovine-based, and looking for a complement fixation reaction. The reagent antigen is cardiolipin, which is present when tissue destruction occurs, and is not specific to syphilis. Therefore, the syphilis antibodies detected in a patient sample are not against the Treponema bacterium, but antibodies produced against substances released by cells when they are damaged. This is termed reagin. Thus, the Wassermann test will be positive in cases of lupus, malaria, tuberculosis, and various autoimmune disorders. It has since been replaced by more modern methodologies. Early treatment utilized both arsenic and mercury compounds. These were replaced with penicillin in the 1940s. Oddly enough, penicillin is still the drug of choice today. Syphilis is caused by the organism Treponema pallidum, subspecies pallidum, of the family Spirochaetaceae. It is extremely fragile outside of the host and is vulnerable to drying as well as temperature fluctuations. It has been found to survive up to 5 days in tissue specimens. Humans are the only natural host. 4 routes of transmission have been identified for Treponema pallidum. The most widely recognized is sexual contact, which requires direct contact with lesions. Transmission by transfusion is extremely rare in the U.S., as all blood products are screened for infectious diseases by the American Red Cross. In the U.S. during the early 1900s, it was more commonly transmitted through the blood supply. At this time, blood was transfused fresh, directly from the donor. Today, all blood donations are screened with the RPR test. Positives are confirmed by FTA antibodies. We will discuss these tests in more detail later in the lesson. The remaining 2 routes are direct inoculation, such as needle stick injury, and transplacental transmission, which results in congenital syphilis. Treponema pallidum enters the human host through abrasions in the skin or by penetrating mucous membranes. Once inside the host, it multiplies rapidly, then enters the lymphatics or bloodstream from which it starts to disseminate to various organs. Invasion of the central nervous system can occur during any stage of syphilis. At this point, there are no clinical symptoms and all serological tests are negative. The average time between acquisition of syphilis and the start of the first symptom is 21 days, but can range from 10 to 90 days. Primary syphilis is the first stage of the disease. This stage starts with the appearance of the initial lesion referred to as a chancre, more specifically a soft chancre, and can occur in single or multiple lesions that develop around the mouth or genital areas. A lesion will start as a red elevated area and then will begin to ulcerate. However, they are painless. Within a week of the appearance of the chancre, the regional lymph nodes can become swollen, but this is not present in all cases. The lymph nodes are generally non-tender. The chancre spontaneously heals in 3 to 10 weeks without treatment. This is the stage at which the disease may be diagnosed by dark field microscopy. Serological tests will generally be positive within 1 to 3 weeks of the appearance of the chancre. If a chancre appears but serological tests are negative, it is likely in the early phase of this stage. Because the ulcers are usually painless and can occur at sites where they are not visible, such as perianally, in the anal canal, inside the vagina or cervix, or not recognized, such as mouth ulceration, many individuals with primary syphilis do not seek medical attention or are not diagnosed at presentation. These soft chancres should not be confused with chancroid, a disease caused by a different organism, Haemophilus ducreyi. Within 2 to 8 weeks of chancre development, signs of secondary syphilis may start to appear. This is often called the disseminated stage. The secondary signs of syphilis may overlap the primary stage, or if the primary stage goes undetected, as in the case with many women, the secondary symptoms may be the first signs of the disease. It usually starts off as a generalized flu-like illness with headache, sore throat, and a low-grade fever. As the disease progresses, about 75% of patients demonstrate a generalized lymphadenopathy. At about the same time, secondary lesions of the skin and/or mucosa begin to develop, mainly on the hands and soles of the feet and on mucous membranes, such as the inside of the mouth, but rarely on the face. Both the primary and secondary lesions contain many spirochetes and are highly infectious. Secondary manifestations usually resolve after 2 to 8 weeks. Around a third of individuals with secondary syphilis have neurological involvement, but less than 1% have meningeal symptoms. Of these, about 2% may develop an acute meningitis with neurological signs of disease. Symptoms can include headache and stiff neck and may involve the cranial nerves, which may result in hearing loss, facial weakness, or visual disturbances. Strokes may also occur. Patients may also develop ocular syphilis, which commonly leads to neurosyphilis if left untreated. During this stage, all serological tests are positive. The latent stage, also called latent syphilis, may last a few months, years, or even decades. The organism remains in the body, but this stage exhibits no signs or symptoms of disease. Serological tests remain positive, however, because of the low numbers of spirochetes. It is not contagious at this stage, though transplacental transmission is possible in about two-thirds of the cases. The diagnosis of latent syphilis is made when an individual has 1. Seroactivity, indicating infection with Treponema pallidum, 2. No past diagnosis of syphilis, and 3. No evidence of active primary, secondary, or tertiary syphilis. About one-third of the cases will spontaneously resolve, though antibody tests will remain positive. Another third remain asymptomatic, but still carry the organism in small numbers. And another third develop late-stage or tertiary syphilis. The last stage, called tertiary syphilis, may occur anywhere from 2 to 40 years after infection if left untreated. It manifests as a slow, progressive inflammatory disease that results from years of irreversible structural damage by the organism. Nowadays, tertiary syphilis is rare because of widespread availability and use of antibiotics. Tertiary syphilis has three major manifestations: gummatous syphilis, or gumma, cardiovascular disease, and neurosyphilis. Gummatous syphilis can occur in skeletal, spinal, and mucosal areas, eyes, and visceral tissues such as the lung, stomach, liver, genitals, breast, brain, and heart. The destructive lesions can clinically mimic carcinoma. The average time of onset is 10 to 15 years after initial infection. Cardiovascular disease results from pathologic lesions of the aortic vasa vasorum. It clinically presents as ascending aortic aneurysm, aortic insufficiency, or coronary osteostenosis due to structural damage to the aorta. In this condition, the vessel walls weaken, become thin, and bulge out, eventually causing a rupture in the vessel, which is most often fatal. Inflammation of the heart valves causes thickening and regurgitation, which is when blood flows back into the previous chamber, which reduces the ejection fraction and weakens the circulation. The average time of onset is 20 to 30 years after initial infection. Neurosyphilis can occur at any stage. Cerebrospinal fluid abnormalities can occur in early syphilis and are of unknown significance in the absence of neurological signs or symptoms, as up to 25% of CSF samples taken during early syphilis can reveal Treponema pallidum DNA via PCR. Structural damage to the central nervous system often leads to blindness, dementia, and paralysis. The degeneration of the spinal cord in tabes dorsalis manifests as a broad, flat-footed gait, said to resemble Frankenstein's monster in the old horror movies. Congenital syphilis occurs via transplacental transmission of the spirochetes from the mother's blood to the fetus. This can result in abortion, stillbirth, active disease, or latent infection in the infant. The fetus is susceptible at any stage of the pregnancy, but is generally most affected during the second or third trimesters. Many infants with congenital syphilis are asymptomatic at birth, but most will develop some symptoms at some point if not treated. Generally, only severe cases show symptoms at birth. Cases are classified as either early or late disease. Cases of early disease will show symptoms in children less than 2 years of age, which is the most common. Cases of late disease show symptoms in children greater than 2 years of age. They may not be diagnosed until after age 10, after irreversible structural damage has occurred. A bright spot is treating a mother with primary or secondary syphilis during the first trimester almost always prevents congenital syphilis. One of the signs of late-stage congenital syphilis is called Hutchinson's triad. One of the triad is Hutchinson's teeth, which results in abnormal tooth development. The teeth are peg-shaped, particularly the incisors, and lesions in the bone surrounding them. Another of the triad is interstitial keratitis, an inflammation of the cornea. Lastly, nerve deafness resulting from damage to the 8th cranial nerve. Penicillin is the preferred antibiotic for all stages of syphilis. For patients that are allergic to penicillin, doxycycline can be substituted. Doxycycline is preferred over tetracycline due to its reduced spectrum of activity. Although treatment will stop the progression of the disease, it will not reverse any damage already done. Some patients may experience what is termed Jarisch-Herxheimer reaction. It occurs most frequently after treatment with penicillin and treatment of early syphilis, especially at the secondary stage. It occurs when large amounts of toxins are released into the body as the bacteria dies, which causes an increase of tumor necrosis factor alpha, interleukin 6, and interleukin 8. The following was reported by a physician after administering penicillin to a patient with syphilis. The patient described feeling cold with worsening headache and chills approximately 1 hour after infusion of the first dose of penicillin. On examination, rigors, shallow inspirations, and chills were noted. He was afebrile, tachycardic, and tachypenic, and had an oxygen saturation of 94% while breathing room air. His symptoms resolved within 10 minutes. Initially, this reaction was thought to be a result of a drug allergy, but upon further review, we determined that it was JHR. On the rise in the 1980s, the incidence of syphilis peaked in the early 90s and then declined, but is on the rise again. 112,501 cases were reported in 1992 versus 6,500 cases in 2001. Part of the decline was due to a U.S. national plan to eliminate syphilis by 2001. Remember that the primary and secondary stages are the most infectious. Increasing rates of syphilis among women has led to a sharp rise in congenital syphilis. The disease is preventable through routine screening and timely treatment for syphilis among pregnant women. The resurgence of syphilis, and particularly congenital syphilis, is not an arbitrary event, but rather a symptom of a deteriorating public health infrastructure and lack of access to health care. The burden of syphilis was highest among men, particularly gay and bisexual men. Men accounted for more than 98%, or 24,724 cases, of all primary and secondary syphilis cases in 2016. Men who have sex with men accounted for 81%, or 16,155 cases, of male cases in 2016, where the sex of the sex partner is known. Syphilis among men increased about 15% between 2015 and 2016, up from 14 cases per 100,000 men in 2015 to 16 cases per 100,000 men in 2016. The table on this slide compares the sensitivity and specificity of the most common tests for syphilis. Note that ELISA has the best sensitivity for all stages, but especially for the primary stage when it might be most difficult to detect. If the primary chancre still presents an active lesion, a direct microscopic exam of the exudate with dark field microscopy or direct fluorescent antibody staining can be used to diagnose syphilis. But usually the opportunity has passed by the time the patient seeks medical attention. In congenital syphilis, direct detection methods may be able to detect the spirochetes in the umbilical cord, placental lesions, or nasal discharge from the neonate. In dark field microscopy, light illuminates the object at a very low angle from the side so that the background appears dark and the objects show up against this dark background. The dark field condenser is a special condenser and not simply the lowered light that is used for examining urinary specimens. The method requires an exudate sample taken from a lesion and smeared on a glass slide. The specimen must be fresh to ensure live organisms are present. This is necessary to demonstrate the characteristic motility. All in all, it is not a very practical method for diagnosing syphilis. Dark field microscopy has the potential advantage of making a definitive and rapid diagnosis of primary or secondary syphilis. However, there are several disadvantages to consider. Number one, it requires an experienced microscopist and specialized equipment, often not available outside of a specialized clinic. Number two, confusion with other pathogenic or non-pathogenic spirochetes may occur. Generally, it is not recommended for oral lesions because of the specificity problems with non-pathogenic spirochetes in the oral cavity. Number three, it must be performed immediately because motility is important for identification. And number four, the sensitivity of dark field microscopy decreases as the lesion heals. The possibility of false negatives increases with the use of topical substances such as soap and water, antibiotic ointments, and others. When using the direct fluorescent antibody or DFA testing method, an exudate sample taken from a lesion is smeared on a glass slide. The slide is flooded with a fluorescent tagged antibody. Excess conjugate is washed away and the slide is examined under a fluorescent microscope. The advantage of this method is that you do not have to have a live organism, and it's more specific. DFAs can be used for tissue specimens as well. The disadvantage is that you have to have an active lesion with an exudate that contains the organism, which is not always the case. Serologic testing for syphilis is an indirect method of detection because we are testing for antibodies. It is often performed when active lesions are absent, as is the case during secondary or tertiary syphilis. Either treponemal or non-treponemal antibodies can be tested for. However, there is a higher chance of false positives with non-treponemal antibodies. Because of the difficulty in culturing the organism and the unreliability of the direct detection methods, Serological methods are the most dependable means of diagnosis. Two types of antibodies are formed in response to syphilis infection: nonspecific or reagent antibodies and specific treponemal antibodies. Usually, a non-treponemal screening test is performed first. These methods detect the nonspecific antibodies. The positives on the screen are then confirmed with a specific treponemal test. Nonspecific or reagent antibodies are formed against a lipid antigen, lipoidal antibodies, from damaged cells. These antigens are also found in many other organisms and some normal human tissues. However, the antibodies are most commonly seen in syphilis infection. The antigen used in the non-treponemal test is cardiolipin lecithin cholesterol, which acts as a lipid antigen. The cholesterol enhances the sensitivity of the antigen. Cardiolipin is not immunogenic by itself. It is too small, generally less than 6,000 Daltons. It is instead considered a hapten. Only when combined with other molecules does it become immunogenic. The limitations of the method include: number one, these methods are not specific, giving a high rate of false positives. Number two, reagent antibodies may be detected in measles and chickenpox, hepatitis, leprosy, tuberculosis, malaria, autoimmune diseases, and pregnancy. Because the tests for reagent antibodies are nonspecific, all non-treponemal positive tests must be confirmed by a specific treponemal test to detect antibodies specific to Treponema pallidum. Very high serum antibodies can supersaturate the antigens used in the non-treponemal assay. If this is suspected, the sample should be diluted. Case in point, a 43-year-old woman has a clinical diagnosis of secondary syphilis, but has a negative non-treponemal rapid plasma reagent test, or RPR, with a titer of 1:1, being undiluted. The clinician suspects the non-treponemal test is a false negative and requests the lab to repeat the test. The rapid plasma reagent test, or RPR, is a rapid method and considered the most common screening test. It is a non-treponemal screening test that detects reagent antibodies using a flocculation method. Activated charcoal in the reagent makes the flocculation visible macroscopically, so no microscope is needed. It has the added advantage of non-interference by complement, so heat inactivation is not necessary. The reagent is stable for up to 3 months. It is a good, inexpensive method and can be performed on a plastic-coated disposable test card. The RPR is more sensitive than the VDRL during the primary stage. However, during the secondary stage, it can be subject to prozone effect, resulting in false negatives. The lower picture is showing a negative reaction for the negative QC in the upper left corner, a positive reaction for the positive QC, upper right corner, and a positive reaction for the patient, lower right corner. False positives can occur in patients with HIV and HSV, or herpes. The VDRL, or Venereal Disease Research Laboratories test, is also a non-treponemal screening test. It too is a flocculation or agglutination method. Soluble antigenic particles coalesce to form larger particles, which eventually precipitate out of solution in the form of flocks, or clumps. It is a very cumbersome procedure. Patient serum is heat treated to inactivate complement. The method requires use of a specially calibrated syringe to perform testing. The reagent must also be prepared on a daily basis due to contamination issues. It is both a qualitative and quantitative test. Quantitative VDRLs require serial dilutions of serum and may be used to monitor therapy. They can confirm and quantitate at the same time. The disadvantages are that it is prone to contamination, must be confirmed with a treponemal-specific method, and there are many false positives. The VDRL CSF is the only test available for diagnosing neurosyphilis. Modifications for testing spinal fluid do not require heat inactivation, as CSF does not contain complement. Nonspecific or reagent antibodies cannot differentiate between the stages of the disease. Reagent antibodies Reagent antibodies are present in primary, secondary, latent, and tertiary stages of infection. Reagent antibodies may not be detected in the earliest stages of the disease, however, as they have not yet had time to form. Reagent antibodies may reach a very high titer, giving a falsely negative or weak reaction due to prozone effect. There are, of course, both pros and cons to consider. The pros include it's inexpensive, rapid, and easy to perform. It may be used to monitor therapy, as the titer will decline if therapy is effective, and can be used to screen large numbers of samples, as most are negative. The cons include many false positives. Reagent titer is highest in secondary stage, so it might be weak in earlier stages. May show prozone resulting in a weak reaction, requires a quantitative VDRL to confirm, and because the tests for reagent antibodies are nonspecific, all non-treponemal positive tests must be confirmed by a specific treponemal test to detect antibodies specific to Treponema pallidum. The tests used to confirm the non-treponemal screening tests are expensive and more cumbersome by comparison. These tests are specific and detect antibodies against Treponema pallidum. However, cross-reactivity occurs with different treponemal diseases, such as Yaws and Pinta, as they cannot be distinguished serologically from syphilis. Once positive for treponemal antibodies, always positive. The titer will remain high, but it does not appear to be protective. These methods cannot be used to detect neurosyphilis or congenital syphilis, as they lack sensitivity. These tests measure antibody directed against Treponema pallidum antigens by either particle agglutination, such as TPPA, immunofluorescence, or the FTA-ABS, or enzyme immunoassay, or EIA. They are best suited for secondary and latent syphilis, as patients may be non-reactive during the primary stage. These tests lack sensitivity in cases of neurosyphilis and congenital syphilis. The tests can help establish a diagnosis in late latent or late syphilis due to increased sensitivity when compared to non-treponemal antibody tests. The immunofluorescence technique, fluorescent treponemal antibody absorption, or FTA-ABS, requires whole bacteria for the antigen. The organism cannot be cultured using conventional media, So the organisms used are a lyophilized suspension of Treponema pallidum extracted from rabbit testicular tissue. This is then spread onto a glass slide and fixed. Patient serum is mixed with an absorbent, the ABS part of the test, containing an extract of a non-pathogenic treponeme, Treponema vagendis, biotype writer. The purpose of the absorbent is to remove antitreponemal antibodies that are not specific for Treponema pallidum. The pre-absorbed patient serum is then added to the slide. If the patient has been infected by syphilis, their antibodies will bind to the bacteria. FITC, or fluorescein isothiocyanate, FITC-labeled antitreponeme antibody, and TRITC, or tetramethylrhodamine, labeled anti-human antibodies, are added as secondary antibodies. The presence and location of the spirochete is identified using the FITC stain, and the TRITC staining identifies whether the patient has anti-Treponema pallidum antibodies that will bind to the same spirochete. Treponema pallidum particle agglutination, or TPPA, uses gelatin particles coated with antigen, whereas Treponema pallidum hemagglutination, or TPHA, uses RBC coated with antigen. Some methods only detect IgG, whereas others detect both IgM and IgG. The use of monoclonal antibodies has greatly increased both sensitivity and specificity, but false reactivity can still occur, especially with Yaz and Pinta. Treponemal antibody titers correlate poorly with disease activity, and they should not be used to assess treatment response. The first step in the fluorescent treponemal antibody absorption test is absorption. The patient's serum is first absorbed with non-treponema pallidum treponemal antigens. What this step accomplishes is the removal of other antibodies that might otherwise cause cross-reactivity. This is why it is called FTA-ABS. If the patient did not have anti-Treponema pallidum antibodies, there will be nothing for the tagged AHG to attach to, so it will be washed away during the washing step. There will be no fluorescence, which indicates a negative result. The absorbed patient serum is then flooded on a slide that has been prepared with whole treponemes. Any anti-Treponema pallidum antibodies present are allowed to react with the antigens on the slide. Next, a tagged AHG, which is AHG attached to the TRITC, is applied to the slide. The excess must be washed away. If the patient is positive, anti-Treponema pallidum antibodies attached to the antigens on the slide and tagged with AHG binds to the patient antibodies. The tagged AHG will fluoresce, which indicates a positive test. If the patient did not have anti-Treponema pallidum antibodies, there will be nothing for the tagged AHG to attach to, so it will be washed away during the washing step. There will be no fluorescence, which indicates a negative result. FTA is not indicated for screening, as treponemal antibodies may be present even after syphilis has been cured. Therefore, it cannot distinguish between active and cured infections. It is only used as a confirmatory test in cases of a positive non-treponemal test. And by the way, both may show a false positive in patients with systemic lupus erythematosus. The advantages are it's the most widely used method for confirmatory testing, it's specific, and it's sensitive for low titers. The disadvantages are it's time consuming, treponemes can be easily washed off the slide, it's not sensitive for congenital and neurosyphilis, and it requires a skilled microscopist to read accurately. The enzyme-linked immunosorbent assay, or ELISA, is a sandwich assay, but can be designed as a one- or two-step sandwich assay, competitive assay, or immune capture assay. With the immune capture assay, wells are coated with anti-IgG or anti-IgM. Patient serum is added and allowed to react. This is followed by addition of enzyme-labeled antigen. The test is highly sensitive during primary syphilis, but the sensitivity declines as the disease progresses. The diagnosis of neurosyphilis is made by testing CSF with the VDRL, as well as some newer ELISA tests and PCR. False positives are relatively rare with the VDRL for neurosyphilis. However, the sensitivity is rather low too, as less than 70% of those with neurosyphilis have a positive result. Therefore, other measures of active disease, like lymphocytosis and an increase in total protein, must also be considered. The non-treponemal tests are of limited use for the diagnosis of congenital syphilis, since they only test for IgG antibodies. We would not know whether the antibodies were from the baby or the mother. Attempts to detect specific treponemal antibodies, that are IgM, by FTA-ABS lack sensitivity in a newborn. The usual protocol is to screen babies of mothers in high-risk areas or with suspected medical histories at birth. Babies are screened at birth with a non-treponemal test, such as the RPR, and if positive, a titer is performed and repeated within a few weeks. If the antibodies are from the baby, the titer will increase, indicating active infection in the infant. Newer FTA-ABS capture, IgM, or Western blot are more sensitive, and the Western blot uses 4 treponemal antigens and shows a high sensitivity and specificity. The Western blot is recommended to confirm congenital syphilis. The Western blotting technique, a molecular method, uses solubilized or recombinant treponema pallidum antigens that are separated in gel by electrophoresis. Then, by blotting the gel, they are transferred to a nitrocellulose membrane. The patient's serum is incubated with this membrane. If the antibodies are present in the sample, they react with the antigen in the nitrocellulose, forming immune complexes, which can be detected by an indicator labeled antibody. As mentioned, this method is used to confirm congenital syphilis. PCR may be used for diagnosing neurosyphilis in CSF samples when negative results are obtained by VDRL. However, PCR is currently limited in use due to the need for more standardization of testing. PCR's sensitivity is highest during primary syphilis, but is greatly reduced in secondary syphilis. Two groups of Borrelia are known to cause human disease. They are Borrelia burgdorferi sensu lato, which causes Lyme disease. The other is the tick-borne relapsing fever Borrelia group, which causes tick-borne relapsing fever. Lyme disease was first discovered in 1975 with the outbreak of juvenile arthritis in the town of Old Lyme, Connecticut. Epidemiological features of the disease earned it the name Lyme arthritis. All the cases of Lyme disease contracted in the U.S. are caused by Borrelia burgdorferi. However, there are actually 3 species that can cause the disease. Borrelia burgdorferi is endemic to the U.S., Europe, and Asia. Borrelia afzelii is endemic to Europe and Asia and is noted for chronic skin disease, or acrodermatitis chronic atrophicaans, or ACA. And Borrelia garinii is also endemic to Europe and Asia and is noted for neurological symptoms. In the U.S., clinical symptoms are more than just arthritis. It is considered a multisystem disease that affects the skin, causing erythema migrans, the typical diagnostic rash. In addition, patients often develop fever, headache, and fatigue. The CDC estimates about 300,000 new diagnosed cases each year. Lyme disease has a worldwide distribution. It is endemic to 15 states in the U.S., as well as Europe and Asia. In the U.S., it is especially prevalent in the northeastern states. Lyme disease is credited for more than 95% of all vector-borne illness in the U.S. Lyme disease cases are concentrated in the Northeast and Upper Midwest, with 14 states accounting for over 96% of cases reported to the CDC. Over 170,000 cases have been reported in the U.S. since 1982. Only 18,000 were reported before 1990. Most of the cases have occurred since, and the increased incidence is thought to be due to better detection methods after 1990, as well as underreporting in previous years. It is still considered to be an emerging disease because of environmental changes, such as farmlands converted to wooded subdivisions. This figure represents the breakdown of reported Lyme disease cases from 2001 to 2016 by disease manifestation. The majority of cases are the erythema migrans rash. Other manifestations are less common, and some patients have more than one presentation. Lyme disease is a zoonotic disease because the primary reservoir for the organism is wild animals. The vector for the causative organism is a hard-bodied tick of the Ixodes species. It carries the spirochete that causes the disease. Only 2 species of Ixodes is known to transmit the disease in the U.S. In the northeastern and midwest regions of the U.S., the species is Ixodes scapularis, and in the western states, it is Ixodes pacificus. Other Ixodes species serve as vectors in Europe and Asia. There is no evidence that Lyme disease is transmitted from person to person. The same vectors and hosts of Lyme disease are also susceptible to other diseases. For example, the parasitic disease babesiosis is transmitted by Ixodes scapularis, and the rickettsial disease ehrlichiosis is transmitted by Ixodes pacificus. The host for the adult stage of development necessary for its survival is the white-tailed deer. The preferred host for the larval or nymph stage is the white-footed mouse. Other mammals, such as dogs, can be incidental hosts and can also develop Lyme disease. Although dogs and cats can get Lyme disease, there is no evidence that they spread the disease directly to their owners. Any stage is infective, though usually it is the larval stage that causes the disease. The reservoir host in Oregon and California is the dusky-footed wood rat. Once bitten by an infected tick, Borrelia gains access under the skin and migrates outward, producing the characteristic bullseye rash. If an attached tick is removed within 24 hours, the chances of getting Lyme disease is greatly reduced, as it takes a while for the bacteria to migrate from the vector. The likelihood of developing infection after being bit by an infected tick is approximately 3%. Two factors influence the chance that a person bitten by an Ixodes tick will get the disease. One is obvious, if the tick carries the organism. The likelihood of infection and the course of disease is now thought to be influenced genetically, particularly for the development of chronic arthritis. Therefore, the second factor is the genetic susceptibility of the person. In the early stage of disease, erythema migrans occurs in about 70 to 80% of infections at the site of tick bite. If present, the rash develops anywhere between 3 and 90 days after being bitten by the tick. The disseminated stage develops if left untreated. It can involve other organs, including muscles, joints, the nervous system, and the heart. Symptoms include fever, chills, headache, fatigue, muscle and joint aches, and swollen lymph nodes. The late stage of disease can occur in patients who have not received treatment. Of these, approximately 10% will develop chronic disease. Some of the symptoms of late-stage disease include arthritis with severe joint pain and swelling. Neurological symptoms may also develop, such as shooting pains, numbness, and tingling sensations in the hands and feet. Facial palsy is a common neurological symptom which results in loss of muscle tone or droop on one or both sides of the face. Inflammation of the brain and spinal cord can cause severe headaches and neck stiffness. Lyme carditis may also develop, resulting in heart palpitations or an irregular heartbeat. In the absence of rash or tick bite history, it is easy for Lyme disease to be misdiagnosed as chronic fatigue syndrome or fibromyalgia. Studies have confirmed that Borrelia burgdorferi is capable of transplacental transmission. Although the disease pattern in the fetus is not well documented, congenital infection has resulted in infant death shortly after birth if the mother received no treatment for Lyme disease. The immunologic response by the infected individual is marked by the development of the erythema migrans rash. It usually appears, on average, within a week of the bite and fades by the third or fourth week of infection. IgM antibodies peak around 3 to 4 weeks, followed by IgG about a month later. The reason for the delay of IgG is unknown, but IgM levels will remain high. This makes evaluation of recent versus chronic infection difficult. It is important to note that antibodies are not protective. When it comes to laboratory diagnosis of Lyme disease, Testing is categorized as either screening or confirmatory. Two common screening methods are the immunofluorescence assay, or the IFA, and the enzyme immunoassay, or EIA. The IFA utilizes antigens which are fixed to a glass slide and flooded with patient serum, presumably containing the appropriate antibodies. If present, antibodies will bind to the antigen, forming a complex. Unbound antibody is washed away, and a second antibody, AHG, that is labeled with a fluorescent tag is added, which binds to the first antibody. Following a second wash phase, the slide is viewed under a fluorescent microscope. The EIA method utilizes an enzyme labeled AHG instead of a fluorochrome tagged AHG to detect the presence of antibodies. It should be noted that false positives may occur due to infections with Helicobacter pylori, Epstein-Barr virus, Ehrlichia, and Rickettsia. Confirmatory methods include the Western blot and polymerase chain reaction. In the reading assignments, be sure to note the difficulties of diagnosing Lyme disease and why serological methods are so important to the laboratory diagnosis of this disease. Prompt treatment with antibiotics, such as doxycycline or amoxicillin, during the first stage of infection seems to be very effective. The biggest challenge with treatment is detecting the infection in the 20% who do not show the rash.